I'm Dr. Derek Lee, and it's my pleasure to introduce Dr. Firoz Miyanji, who's a pediatric orthopedic surgeon at BC's Children's Hospital. He's also part of the orthopedics department at the Faculty of Medicine at the University of British Columbia. Welcome, Dr. Miyanji.
Thanks, Dr. Lee. Pleasure to be here.
Was medicine pretty well clear to you when you're younger, or is it something that you developed an interest in over time?
Great question. When I look back, I mean, I grossly thought of medicine, and then you know, as you mature and you go through your studies, I sort of navigated a little bit more towards it. But for me, it was really a sense of mentorship that kind of drove me which way to go. So I really credit many mentors I've had, you know, teachers at the beginning and professors and others that I worked with that kind of steered my career path. So I've been very grateful.
Okay. So you received your medical degree from the University of Ottawa.
Correct.
And a residency at University of British Columbia, where you
Correct.
have great loyalty. And now you also had a fellowship at Toronto Western Hospital, and you spent a year in San Diego. See, I stalked you quite a while there, right?
That's all correct, yes.
Now, in San Diego, was that your first exposure to tethering?
In San Diego, actually, in San Diego, it was, when I was there, it was actually pre-tethering for clinical trials.
Okay.
It was at the basic science model. So I certainly credit my knowledge, my introduction to VBT at a way well before even clinical proof of concept to Peter Newton. He was doing, and he really pioneered thoracoscopic approaches to the anterior spine. And at the time, I was actually down there to do anterior fusion surgery. So to come back to BC Children's and potentially give an opportunity for patients to get fusions from the front through a scope. It's just that at the time, other things were developing and that sort of started to decline, but Peter was doing a lot of basic science models and sheep in that at the time I was down there in San Diego. So it was really exciting, but it was extremely, I'd like to use the word, not really immature, but it was at a very sort of infancy level of VBT and what it meant. And we certainly had discussions about growth modulation. So for my experience and my sort of delving into VBT, it was very much at the basic science level.
When did you feel that VBT was an option for you to explore more? Once there was more research, more information?
Good question. It was really peer-to-peer discussion. So myself, Dr. Samdani, Dr. Betts, Dr. Newton, and a few others had a meeting in sort of about 2010, 2011, I like to think about around that time, looking at, you know, is there something now FDA approved for implantation and whatnot, et cetera, to look at the possibility of moving this into a clinical proof of concept. We looked at other patient populations, neuromuscular, idiopathic, et cetera, and then it was sort of, you know, cautiously considering where we can kind of introduce this technology. So it was way more sort of a peer-to-peer discussion, looking obviously at the proof of concept out of basic science and animal model, and then to introduce that into a clinical setting.
Well, with Dr. Peter Newton, I hear he's an extremely skilled surgeon, number one. And number two, his current research seems to focus a lot on bone modulation and and going into and especially the 3D sagittal plane. Do you find that the consensus right now around scoliosis, of course, it's still quite a few unknowns in terms of the trigger or the cause, but once it gets rolling, there seems to be a little bit more consensus in terms of anterior vertebral overgrowth causing wedging A to P in the vertebrae that drives the spine into hypokyphosis, maybe some lordosis, and causing rotation, and then the coronal scoliosis curve. Is that correct, as far as you know?
Yeah, I think you know it's sort of a school of thought of where you feel you know the etiology biomechanically basically lies with scoli, and it's always been you know this RASO or relative anterior spinal overgrowth driving a lot of things, and I think that was the premise of having attempting to modulate the growth from the front, so that you can then almost quote reverse the changes exactly as you're talking about, right? The lordotic nature of the spine in idiopathic scoli, their you know coronal plane as well as the rotational profile. So that's the reason I think VBT has sort of focused on doing it from the front as opposed to just from the back, because I think if you really look at the vertebrae and its growth plates and where you might get your bang for your buck for modulation, it's still, in my opinion, still from the front, and especially those that you know have invested in the concept of VBT. I think that RASO ideology, or that RASO relative anterior spinal overgrowth is something that I still you know I still think of, and I agree with. I do think that is a primary biomechanical driver for the deformity you're seeing.
Because initially, when I was doing some research into growth modulation and VBT, I always was focusing more on the coronal plane in terms of the vertebral wedging from side to side, right?
Right.
And it's only when I started to do a little bit more research and the RASO and looking at the anterior overgrowth, do you think, well, obviously, I don't know, let me ask, is it the overgrowth that starts first? Yes, then it causes rotation. And
Yeah, great question. I don't know, and I don't know if we figure that out. You know, it's always sort of the chicken and the egg. You know, the Hughes-Volkmann principle is also very closely related. But then, what is it that drives it? Like, how does the wedging occur initially? What kind of does that for that Hughes-Volkmann and to, you know, to overcome and really compress those concave growth plates? So again, great question, but I think there's still a lot to learn. You know, people like Peter and others that drive, you know, the basic science and the biomechanical studies, you know, credit to them to kind of increase our understanding of this.
right, because I know with in terms of the lateral wedging, there does seem to be remodeling, but I was wondering if anyone has really dived into any remodeling A to P as yet.
Correct. So yes, Peter's looking at that as well. So now that you know there's the EO system, you get a better three-dimensional kind of reconstruction. So you know, without spoiling maybe some of his research coming out, he's definitely looking into that, and it is looking promising. You know, we look at that indirectly, not at I think at the level maybe your question is directing at, but grossly when we're looking at X-rays. One of my concerns, of course, with VBT was, you know, producing too much kyphosis. And say if a patient wasn't truly hypokyphotic in the thoracic spine, say they were neutral, or maybe they had a bit of kyphoscoliosis and you did a VBT, could they get very hyperkyphotic? And thankfully, just looking at the radiographs over time, that's not happening. So I'm excited about that. But looking at, you know, that A to P growth as well, Peter's got some very nice slides that, you know, he's shown us, but I think hopefully you can get a paper out and we can all see that globally.
Sure. When was your first VBT surgery?
I believe it was either late 2011, early 2012. It was around that 2011, 2012 mark is the first VBT we did here at Children's. Yeah.
Terrific. Was that in partnership with Dr. Perrant, or were you guys kind of doing this same timeline but in different parts of the country?
No, it wasn't in partnership with Dr. Perrant. I basically, you know, I had probably a little more communication with Dr. Simdani and Dr. Newton at the time. So we did that first procedure in Canada with the old Dynesis system in Vancouver. And I'm not exactly clear when Stefan you know, introduced VBT out at the East Coast, but I think it was probably around the same time. And then we both we're both Newton fellows, and so it's been pretty near and dear to both of us. And so I think it was nice because on one side of the country, he was able to possibly offer it, and we were on the West Coast, and so that's how it sort of started to stem. Yeah.
So you have the distinction of being the first VBT surgeon in Canada, then.
Oh, I don't think it's much of a distinction. That's nice of you to say. I don't think it's much of a distinction. I think we just, I think it's just timing. I think everybody was thinking of it, and you basically weighed risk benefits. Look for the ideal patient population, and then and move forward. But honestly, especially in the Canadian system, there's definitely no race to a finish line, right? I mean, we all been gaining a lot of knowledge. With the collegiality that we've had from one center to the other and stuff. So I think it's been really good.
That collegiality, is it more national or is it international at this point? Because there's so few spine surgeons to begin with, and then even less, probably 10% of those do VBT max, right? Probably maybe about 5%.
Yeah, and I think because it's a small community. I think that's one of the beauties of it. We know each other personally as well, and it's been extremely collegial. Like I really have benefited from knowing people around the world, learning from them as well, and so I really think we're fortunate. Sometimes you get into a niche and you're like, you're only one or two in a certain kind of territory that's doing it, but there's only one or two in all the other places, and then you just connect, and it becomes really, it's a lot of fun. To be honest with you, right now with COVID, many of us are doing Zoom calls, and we really are, we really miss that face-to-face interaction at meetings and the academic exchange and, the rich sort of knowledge that you can learn from each other. It's really, it's been tough, honestly.
Well, to be honest, I'm missing those as well, because you have the best research abstracts that come out of those with the current information. What are your current rates in terms of tethers breaking?
In terms of our tethers currently breaking, so I looked at this data with Stefan's data as well for patients that were at least 2 years and more through a prospective database where we were collecting. So of those that sort of qualified within that category were 124, and of them, 35 had broken tethers. Having said that, very, very, very few, I would say, maybe a handful at most, required a repeat procedure for the broken tether. What we found when we looked at that subset of 35, we found that by the time they got to the most recent follow-up, they had on average increased their cob angle by about 5 degrees. Did that, really change anything? It didn't. But it's important knowledge to know, because I think initially, as you've identified, there was this worry that, oh gosh, the tether broke, now what happens? But I really think it's a balance on when it breaks, how skeletally mature the patient may be, versus, how skeletally mature they may be, and then whether you really need to do something or
not. 100%, because speaking with Dr. Samdani, he was mentioning that originally when they're starting out, his first 100 patients, the tether rate of breakage, the tether failure was quite, maybe around 40%. Right. But out of that, very few are actually needed revision. And he actually prefers that once they hit skeletal maturity, that the tether would break in multiple places just to free it up as much as possible.
Interestingly, when we had our first initial discussions, like prior to, I'm not even sure a handful of patients even having this around the world, to be honest with you, it was sort of like, how should we roll this out? And the concept was 2 consents, one to put it in and one to take it out. Because Peter's basic science models biomechanically showed that, flexion, extension, and lateral motion was maintained in a tether. What was diminished was lateral motion away from the tether. So if you released the tether or took it out, you essentially could be back to completely normal motion per segment. But of course, it's an anterior procedure with a scope, etc. Most patients are like, I'm good the way I am, and I really can't tell a few degrees moving laterally. So I think Amir's right. Like if you broke it at multiple places, you probably get a little bit more motion anyways, right? So I agree with him. I don't think it's a bad thing.
Did you find that most of the revisions, if you needed to make a revision, was at, especially at the beginning, were due more to overcorrection than tether breaking?
Yes. So yeah, my revision rates for now have been 3 patients for overcorrection, 2 patients that added on. So we didn't do their lumbar curve initially, and then we needed to go back and do their lumbar curve. So I guess the challenge is that truly a revision, or is that just another procedure? And then we had one that we converted to a fusion.
Now, a question I've never asked before, and I'm curious,
Sure.
is there some kind of protocol? Let's say you have a single thoracic curve, and you have, say, a 50-degree Cobb angle. How do you know how far up to go in terms of the levels to tether and the tether, and how far down to go? Is there some kind of formulation?
Yeah, there is actually. So we've extrapolated that from our anterior fusion rules. So if we do, say, in fusions, we can do them from the back, we can do them from the front. And if we do them from the back, we have different rules of how high and low we want to fuse. If we do them from the front, we have different rules. So historically, because of the biomechanical sort of implants that were available at the time, the anterior fusions generally were a couple of levels shorter than the back, because from the front you would go from end vertebrae, so the most tilted vertebrae, to the most tilted vertebrae down below. So you're going end to end, so you take the full Cobb. And we've extrapolated that to our VBT because we're doing the procedure from the front. So in the purest sense, when you're doing a VBT, in my opinion, you should still respect those anterior rules and go from end vertebrae to end vertebrae. And that's the top to bottom kind of concept of what you're trying to achieve for your construct.
Thanks for explaining that, because it's
Yeah.
it's interesting to hear the logic of it, because it makes complete sense. You just take your experience from another procedure and you roll it over onto and hope it works, right? Initially. Yeah, for sure. Fascinating. Anyway, a question I also have is, there's been a little bit of a trend lately, but because your rates are so low in terms of tethers failing, of doubling up tethers in certain areas, like the lumbar spine for more stability, that type of thing. Do you generally stick with singles, or? Yeah,
I've only done singles. I still think, that sort of, in my opinion, why I've enjoyed sort of how VBT is developed is, credit to, minds of like Peter Newton, et cetera, that you take a basic science model, you have proof of concept, and then you go on. When you start adding, double tethers, et cetera, these are sort of more kind of opinion-based concepts to put in and whatnot, et cetera. And I think you probably want to establish some knowledge at either a bench model, biomechanically, et cetera, to, again, weigh the risk benefits. Like if you did put a double tether, you might say, well, I've got I'm able to prevent tether breakage, but you might have a stiffer construct, because in the end, right, we're trying to preserve motion, right? So sometimes we change the goalposts. We're initially going VBT motion, and then we say, okay, goalposts over here, because now we're going for deformity correction. And then goalposts over here, because now we don't want the tether to break. So you're mixing and matching everything, and then it becomes very confusing. So I just like to keep it simple. We want to preserve motion. Is this working? Is it not working? If it's not working and we have way too many tether breakages that we need to introduce something stiffer, i.e. a double tether or some other cord or whatnot, we need to test it mechanically. Like, will a double tether still preserve motion, or is it going to be so stiff like a rod? So then what is the point there? We might have to go back to the drawing board and reintroduce stuff. So I'm very cautious in introducing something, especially surgically, like you're implanting something in somebody's body, that's in a child, right? So I'm very cautious, and I'd like to kind of, dial back a little bit and look at the basic science model and feel that it's my responsibility to establish that, and then go ahead and say, okay, you know what, now clinically, we can do this because our goalpost of maintaining motion is still valid.
With respect to your parameters, are they similar to the FDA's?
They are similar to the FDA's, apart from probably the minimum requirement. Like a 30-degree curve to me is definitely way too small. So for me, it's still 40 and above. And then that 65-degree, I think, is still good. I may be a little bit more aggressive on the forefront of a lumbar curve. Like if it's 70 in a small child, I will probably consider that, because I have found that the lumbar curves modulate very differently than the thoracic spine. It's probably because of the mobility, no rib and chest cage constriction, etc. So I'd say probably on the higher end, a little bit more for lumbar curves, definitely at the lower end, not down to 30 degrees. And
speaking to surgeons, it seems to be based upon judgment as well, if they stretch that a little bit, depending on, Sanders score, that type of thing. And speaking of that, Sanders score, is there a perfect Sanders score for the optimum VBT outcome?
Yeah, I mean, in my opinion, when I look at the data, I'm still thinking that the Sanders 3 looks pretty darn good to me. And those ones in our database have been doing very well. So I think a Sanders 3, but again, that needs to be balanced by the size of the curve. So it's not just skeletal maturity. It really needs to look at, the patient's curve magnitude and its flexibility. Mm-hmm. I think those two things also are very, very related to the Sanders score. But right now, what I feel is a 3 seems to be a good sweet spot to look at.
So 3A, 3B within that range for sure.
Yeah, absolutely.
Okay. Speaking of stiffness of curves, some surgeons feel that if you look at the disc, and especially if you even if you make a small incision, that you're causing failure to the integrity of the disc, right? And it's going to lead to perhaps faster degeneration, autofusion, that type of thing. While others feel that you need to release the disc, depending on what magnitude you use, to reduce the anterior column to make space to derotate. Where do you fall along that spectrum?
Yeah, I'm nowhere near disc releases. Again, I think you're changing that goalpost and looking for other things. If you have to release a disc to get correction, the curve is far too large, in my opinion, to be asking VBT to do what you need to do. You have to have a frank discussion with the family and say, fusion should be considered in this instance, because now doing hybrid procedures where you're releasing disc and the annulus, et cetera, I mean, you're causing trauma to something, and that's not going to bode well. The whole purpose of the VBT is really to maintain motion and preserve dysfunction. To incise it, it definitely causes an integrity issue. I mean, look at a patient that has had a disc herniation. Yeah, if they have true disc herniation and they're not amenable to conservative therapy, they may get a discectomy, but that annulus is always torn. It gets scarred down. And if you look at them long term, that area gets degenerated. Now, that was an auto, an auto process where the patient ruptured their annulus and had a herniation, et cetera. For me to do it iatrogenically and then claim that it's going to be just fine. Again, I think there's definitely great basic science model, great information from the adult degen literature, that discs are very sensitive to manipulation and incising with a knife to say that, it's all going to be fine. I think that can be a little misleading in my opinion. So I don't do any disc releases.
Is there a specific instrumentation available in Canada for tethering? There seemed to be a little bit of time when there wasn't, and I don't know what the status of that is.
Oh, sure. So the FDA approved system, we were lucky enough to have that available as soon as it was ready. So we didn't have to wait for the FDA approval of the Tether system with Zimmer. So we've been using that at Children since 2018. So that's the system that's available now in Canada for us to be able to go ahead and use the VBT. Again, I can't speak to the other centers. I know in the US now, because it's FDA approved, it is released as an HDE, which is a humanitarian device exemption. So the centers need to have an IRB in place that, they're going to be following these patients. They're not just implanting and letting them go. And then I guess they can have the implant available to them. But right now, to my knowledge, the only FDA approved system is the Zimmer system. And in Canada, that's what I've been using since 2018.
With respect to Zimmer, is that there's a bit of a race with Globus, et cetera, and other companies in terms of trying to develop a bit of a stronger tether. Do you have any idea of when a possible stronger tether would be introduced?
Oh, wow. No, my friend, I have no idea. No, I actually didn't even know they were doing that. So I don't know. I don't know. I mean, I guess, they may be looking at, their failure rates, et cetera, and then looking for something stiffer, stronger, but I don't know. I would think it might be, it might take some time, because I would think that that's going to take a lot of rigorous sort of biomechanical testing. And then how that gets rolled into the market and FDA and all that kind of stuff is probably a longer road than I would have knowledge about. But I don't know. I'm sorry.
My experience with Dr. Samdani and with my son, he was tethered about 6 months ago for a thoracic. So it's quite the experience, and it's fascinating technology. And my son is very hypokyphotic as well, lordotic in his upper back, and very little flexion into his thoracic. So that's kind of why I'm always asking questions about, have you seen any kind of growth modulation enough to see any increase in or reduction in the hypokyphosis?
Right.
Have you noticed?
I have. I have had one patient that was really, really lordotic, and that patient, maybe got to neutral, didn't modulate to a point of kyphosis that I think would have been ideal in my opinion. But generally, I have seen them modulate nicely in the sagittal plane because of that. Again, my initial concern was over kyphosis, but they haven't done that. And I've had one patient which was really, really lordotic that that modulated modestly, but not enough, I think, in my opinion.
What do you see developing with respect to VBT over the next 5 or 10 years?
Great question. I think there's going to be a mixed bag. I think there's going to be good success, and I think there's going to be failures, and I think it's going to be our responsibility to learn from that. I think, as surgeons and caregivers, much like yourself, is our responsibility to move ahead cautiously. I think it would be very disappointing if this was sort of a flash in the pan kind of technology, because we as surgeons weren't good stewards and maybe did this in indications that weren't warranted, and then the failure rate is really high. So I strongly think that I think it is a place, but I think there is a particular population that it will address. And it's not a panacea for everybody. And I totally understand that, the word non-fusion and the word fusionless, we get very tunnel vision to say that's all I want no matter what. But we have to be honest and say, in some instances, unfortunately, we just haven't figured it out. And I really use the analogy to arthroplasty. Both, take the total hip, for example. A total hip arthroplasty is actually the surgically best known procedure to date. It far outweighs the outcomes of cardiac surgery and appendectomy and ACDF. Like, it is the best known surgical intervention to date. So if somebody has osteoarthritis and they get a total hip, they are going to do super well. Having said that, though, even 20, 25 years ago, the total hip was reserved on an age cutoff. If you were 65 or above, you can be considered for a total hip. If you were 60 or below, it's like, because they knew that after 10 or 15 years, you needed to revise. 65, 10 or 15 years puts you in an age range where, you know, the revision rate will probably, your life expectancy would probably be beyond needing to take you back to the operating room for revision. Now, having said that, over the last 20 years, technology really has gone, you know, up a steep slope for arthroplasty to a point where the liners, the metal implants, their ingrowth, all that stuff has, you know, been so successful that they offer a total hip in like 20-year-olds now, right? So, I mean, it's a vastly different game now for total hips, but I think they've gone through it in a nice, you know, manner, and now they have expanded, you know, their application of a fusionless procedure, because the old school of arthritis in your hip and knee required a fusion. You fused that joint, took the motion out, no pain, but you can't move. Now you don't even hear of it. Nobody even, you know, you'll never talk to a patient and say, hey, you know what? Oh, you're arthritis. Let's fuse that joint. You get arthroplasty. That's just the standard of care. So I think, you know, for VBT, that's the analogy that I try and keep in the back of my mind, that, you know, we're not there yet. We're in its infancy. We're trying to pioneer stuff. And if we're just patient enough and we move cautiously, that hopefully we'll be able to expand it and just say, you know, for Scoli, we've got a fusionless option. Because I think that's been the biggest challenge with deformity surgeons is, yeah, we can make the spine straight, we can prevent the progression, but technically, and it's always been at the expense of motion because we're fusing your back. And it's not something we've wanted to do, of course. It's the option that we've only had.
Absolutely.
But that's where I see sort of that spectrum of VBT going.
Yes, some surgeons have mentioned that to them, the top priority is not getting the best correction. It's, you know, if you can reduce the chances of them getting future fusion by like 90%, then that's a success.
Right. Correct.
Right.
Correct. Absolutely. Yeah.
Yeah, for sure. Now, with respect to surgeons in general, when you're adopting a new technique like yourself, that must have been a tough thing to do in terms of, you know, Canada socialized medicine, bringing in a new technique that's at the ground level and then growing it. How did you manage to do that? And why is it not happening in Ontario more? Toronto. I noticed Dr. Smith in Ottawa, and the only one, right? But
yeah, well, you know, I guess you know, as a surgeon, you know, for those that haven't looked into it, I mean, you know, whatever procedure you do, as you know, you're essentially consenting a patient and a family to, you know, to assault their child with a blade to try and get them better. So you want to be pretty darn confident that what you're going to introduce is going to change the natural history for this child for the better, right? Otherwise, you do no harm, you do nothing. You don't even offer surgery. You know, you definitely go with a bracing protocol, etc. I think the non-operative sort of mentality really needs to be first and foremost, and then you consider the operation. And then there's two things, right? One is training. So generally, you know, where you've trained and how you've trained, you're going to be comfortable with a skill set. And then, you know, it's sort of, you know, I guess that also goes on to what skill set that you may have now to offer it, and whether, you know, you either have the time or energy to look at, you know, something different or new, and then realize that I need to introduce that. And you just may have that sort of philosophy that, you know, we need more data, and we need established data, and let a few do it to get the information and then establish it. And I think, you know, as surgeons, you know, in a broader context, that's generally how people have done that. And I think it's a good thing, because I think first and foremost, it establishes that, you know, the surgeon community, you know, firstly believes in safety, right? And I think that has to be high priority on anybody's list. And then say, fine, you know, give me the available data, and then look at that critically, and then say, okay, fine, you know what, now there should be adaptation, you know, across the board. How long that takes will definitely be on a surgeon preference and more on a surgeon personal level, but I just think that those are kind of the steps that we need to do. I mean, my first initial discussions with patients for consent was was tough, not because I really needed to make sure that I wasn't entering a room and convincing them to do something that I wanted them to do. And it was a really tough balance to say, you know what, there's potentially another option. You know, we've got really good basic science model. There's been one published data of clinical proof of concept, and I just wanted to speak to you about this and give you and then gave them some time to think about it. We went back and forth with questions, etc.
Mm-hmm.
Now it's almost the opposite. Patients are coming in and saying, look, Miyanji, I got a 90-degree curve and I'm like 21, I want a VBT. And I'm like, oh my goodness, we need to talk. So you know, it needs to be balanced. Having said that, you know, we practice in a very different world now, right? I mean, we practice I personally think in a really good state. Patients are coming in educated. You know, they you know, they don't just look at me and say, what do you want me to do? Tell me now, and that's it. They're very much into like, listen, you know, I've looked at options. I think for me, myself, as a child of 12, this is what's important to me. And even right now, I discuss both fusion and VBT. And I also ask them, maybe, you know, give me your goals of why VBT is important for you. Give me your goals of what you think fusion would be good or bad for you. And let's kind of come to what's best for you. Right? Because all these population studies, all these, oh, you know, somebody did well here, somebody did well here. Look at the number of here. We've got 35 tether breakages out of 124. What does that mean? It's important to give you, you know, broad knowledge, but I still think case by case, as a surgeon, you really want to, you know, you really want to be as personable as you possibly can for that family and that patient to do what's best for them and that child that's in front of you.
No, that's I 100% agree, and that's kind of when I went for my first consult with Dr. Sam Danny. I almost felt like he was trying to talk me out of it. I'm going to fusion, right? I said no, I want this one, but it was. I understand the approach from the surgical point of view because you have to be completely transparent, right? Yeah. Now, in terms of I do hear that you have been training some surgeons in Canada for VBT.
Yes.
Are you noticing you're getting more inquiries to do that, or?
Yeah, I mean, we have, yeah, absolutely. We have established. I'm just trying to think. I don't want to use the word only in Canada, but possibly one of the very few centers in the world that offer just a pediatric spine fellowship. So these are surgeons that are fully trained. Some have already done a spine fellowship and they come only to spend a year doing pediatric spine alone. And so I think the VBT flavor, in addition to other stuff that we do, has kind of sparked their interest. So I definitely have trained, you know, a surgeon in Edmonton, another one back in Montreal. In fact, two are back in Montreal. You know, Kevin Smith in Ottawa wanted to spend some time out here, but West Coast was too far for him to come. So I think he went out to Montreal and did some cases with Stefan Perron. So I think it is a small community, and we're definitely getting a lot of interest. I am getting a lot more interest from U.S. surgeons to come up here and train. You know, I think have VBT under their armamentarium as an option for patients. So training wise, I completely agree with you. I think it's also all responsibility. And I think when you train, you know, in your fellowship years, to go to a center that's offering new stuff is good because, you know, it's not just the technique, but I think the surgical decision making. I mean, they spend time with us in clinics, seeing the patients, you know, who's it working on, who's it not. So it gives you a little broader kind of a concept in doing something like that. So we are seeing a significant interest, which is good for our fellowship, and so it's been really good.
That's good to hear. Well, I'm sure surgeons are seeing the potential, and now that there's more data, they can make more of a commitment in investing time and energy into training.
Yeah.
Just one more question for you. In terms of initially, who trained you initially in the process of VBT?
Peter Newton. I credit, you know, I've been very lucky, I think, in my training. When I was out in Toronto, actually, he works a little bit at Sick Kids, but Stephen Lewis, who I think is one of the one of the world's magicians in deformity surgery. You know, he does big cases, he does them extremely well, and he's just an outstanding sort of thinker, and you know, the way he approaches patients and all that kind of stuff. So I really lucked out with my training as a fellow, both out in Toronto, and then I spent the year down with the San Diego group, and you know, doctors Wenger, Mubarak, and Peter trained me. And so for that, I was extremely lucky, because by the time I came back to Children's here, doing a scope from the front was not, I mean, it wasn't as onerous. Like I didn't have to relearn some skills. I've spent a year with Peter Newton of All People, and it was just amazing, because, you know, you learn the nuances, and you can approach the spine, and, you know, we instrument it. So it's not, for me, a VBT is kind of like, oh gosh, I'm learning a whole new set of skills. I had the skills established through my fellowship, and so I credit, you know, those four, Steve Lewis, Peter Newton, Dennis Weiner, and Scott Mubarak for letting me, you know, have a set of skills that I'm comfortable with. That for me, VBT right now has been patient selection. Honestly, that's been my sort of focus. Not how do I get in the chest, where do I put my ports, how do I take down the vessels, and like that. We do our own scope, so I don't have an access surgeon. And again, I credit that to the training gods that have been very gracious, you know, giving me the training that I needed.
Well, I've always been a proponent of you're making your own luck. So
Sure.
I'm pretty sure it wasn't all chance. You knew what you were doing, which is good.
Thanks. Thank you.
Right. I want to thank you for taking the time to educate myself and the viewers so much. Really appreciate your time.
My pleasure. It's been great.
Anytime. Maybe we'll do this in a couple of years to see what
sure
have been made.
Absolutely, yeah. Great talking to you. Thank you very much, Dr. Lee, and have a great weekend.
Thank you. Bye for now.
Okay. Bye-bye.